Well, hey guys, my name's Kevin, practice educator on Vancouver Island, and today I thought that I would put together a little video, just talk about some of the nuts and bolts of anaphylaxis. So for this video, a couple of things. I'm just getting over this little black eye right here, so I'll leave the genesis of that to your imagination. This one here is just puffy because I'm old. So yeah, that's the way that works. Anaphylaxis, it's going to be a fun little topic. If any of you suffered through the anticoagulation 28-minute video a couple of weeks ago, good on you. But we'll try to keep this one a little bit shorter and a little more to the point. So anaphylaxis is obviously a very dangerous medical emergency. We come across it fairly frequently, actually, in BCHS. I didn't bother to pull stats from PCRs and stuff, but I know that it comes up fairly often. So it's not unreasonable to think that many of you might encounter that, especially in the summers. There's more allergens out there that could potentially cause problems for folks. What are some common allergens or things that cause allergies and anaphylaxis in people who are prone to it and sensitized to them? Things like, your typical bee stings, different food, if people have severe food allergies, like shellfish, that kind of thing. Some environmental factors, grass, pollens can cause it in very sensitive people. And then, of course, medications that are either ingested or injected. So all of these things can lead to anaphylaxis. And one of the key points in dealing with it is dealing with it quickly. Don't sit around and wait and think about it or Google it or something like that. Probably just give them some epi if there's any indication that anaphylaxis is developing. We have guidelines in our CPG as to what defines anaphylaxis. But one of the biggest issues that arises with anaphylaxis treatment is that usually people wait too long. So if you have a history of an allergen, exposure to an allergen, and you have some body systems affected, some hoarseness, edema, abdominal pain, hypotension, you're going to want to treat that pretty quickly with epinephrine because the benefit there is far going to outweigh the risks. So anyways, that said, let's just jump in a little bit to anaphylaxis. I'm not going to talk about how it develops in the beginning. It's a whole complex system of how you get exposed to an allergen in the first place, and your body goes, meh, and then it gets all excited, and next thing you know, you have an allergy or a history of anaphylaxis. But what happens when we go to a call and somebody has been exposed who is allergic to something like the bee stings or a food allergy or something like that? So right here, this little triangle right here is going to represent an allergen, whatever one you want. I don't care, pick one. And what we see happening with an allergen is that it goes and mostly attaches to something called mast cells. And mast cells are present all over the place in the body, especially in mucosal tissue, lungs, in the bloodstream, around smooth muscle. You're going to have mast cells sitting there. And once somebody is sensitized to these, lots of these mast cells will have what's called immunoglobulin E or IgE attached to it. And those things are sensitized to that particular allergen. So you just have mast cells sitting in your tissue with these little things sitting there just waiting. What happens is all of a sudden you get stung by a bee, and that bee venom goes down or whatever and hits these little IgEs sticking on a mast cell, and the mast cell is like, damn, it's time to do something. So what does it do? Well, it just reacts. It just goes nuts. And what happens is mast cells have all these little granules in them all over the place, lots of them. And these mast cells start to kick out these granules. They just go and they out of the cell membrane and they're released into the surrounding tissue. So all of these little mediators that you can see represented right here, the biggest one we tend to think about is histamine. So histamine is in there. Histamine comes out and it causes a lot of what we see or what we associate with anaphylaxis. But it's not the only thing that comes out of there. We also have things like tryptase, tumor necrosis factor alpha, a whole bunch of other things. I'll put a little very in-depth article in some references at the end for you. And if you really want to nerd out on this stuff and get deep, it's got it in there. So histamine, tryptase, tumor necrosis factor alpha or TNF alpha, all these things come out and they're all mediators of that anaphylactic reaction. At the same time, these cells and the other cells that get signaled start to produce other proteins and other things that are all part of a sort of dysregulated immune response. And that wacky immune response, you can see stuff called what's called platelet aggregation factor and the histamine. These can all get together and actually stimulate the production of something called nitric oxide. Nitric oxide is always going on in your blood vessels, and nitric oxide is really actually a potent vasodilator. So all of these things together, and all of these mediators, the ones that come out of the granules here, the ones that get made, these all have a systemic effect. So what happens? This is where we see the signs and symptoms of anaphylaxis. We get bronchoconstriction, we get edema, we might get urticaria or hives on the body. You might get the angioedema where you see swollen lips, which I have had, by the way, to some antibiotic and is weird. And you also start to see the effects on the cardiovascular system, where you see maybe a little bit of tachycardia, but you also start to drop your blood pressure and stuff. So let's just talk about that. So with all these mediators come out and hit stuff like the blood vessels, here's a picture of a normal blood vessel, okay? And this blood vessel, it's just chilling, it's hanging out, right? It's got a happy little red blood cell in it. It's like nice and full, got lots of plasma, lots of stuff inside of it, it's just doing its thing. Then all of a sudden, these little guys come out and get released. Boom, they hit the cardiovascular system. Well, what happens? It causes vasodilation. This goes from being nice and tight and together and just a normal blood vessel to all of a sudden, poof, it's big, it's huge, it's vasodilated. At the same time, it gets leaky, right? All these gaps between these endothelial cells or the lining of the blood vessel gets leaky and starts to let fluid leak out. What happens? Well, our little red blood cell gets sad because there's no fluid left. It starts to leave the cell. It has a big vasodilatory effect. And as a result of this is when, boom, we see shock. Mostly distributive shock, if you want to talk about the shock states, which if you'll remember, there's distributive, there's cardiogenic, there's hypovolemic, and then there's obstructive shock. We're mostly talking about distributive shock when it comes to anaphylaxis. You can make an argument for a bit of hypovolemic shock because fluid is getting out of the CVS a little bit, but really we're talking about distributive shock as a cause. Big wide blood vessels leaking out, plus we have all the other effects that we talk about, the itchiness, definitely the shortness of breath and the swelling and the edema, which is also sort of a result of all this vasodilation and leakiness. So all that being said, once we have all these systemic effects going on, what do? Well, I think it's no surprise to anybody. We give epinephrine. Give epinephrine. Epinephrine is great, fixes this. It's a great thing to do. Epinephrine works pretty much all the time. There are a few select cases you'll read about that'll say, well, epinephrine might not be effective and maybe we need to do something else. But for the most part, if we attack this, 99% of the presentations you see, it's going to be epi. But you might need to redose it too, up to like almost 36% of people, I think 12 to 36%, a wide range of people actually need a repeat dose of epinephrine. So never a bad idea to drop and have a second one ready. If you sort of treat at the scene and then maybe you're transporting, have some more ready in case those symptoms recur or get worse again. So epinephrine, just to recap, what's the dosing? In adults, we give 0.5 milligrams IM. So in a 1 cc syringe, you're gonna have half of that filled up. You're gonna have 0.5 milliliters, which is gonna be 0.5 milligrams of epinephrine. In kids, we're gonna use 0.01 milligrams per kilogram. So a 20 kilogram kid, what's that, 45 pounds-ish, will get 0.2 milligrams per kilogram, all the way up until you hit the 0.5, which is the max. And then a little star here for ACPs or maybe CCPs. You can actually, in like really super sick peri-arrest, or maybe if you haven't gotten an effect with your first epinephrine or whatever, there is a consideration to give 50 to 100 micrograms of epinephrine IV, but that's kind of reserved for a very serious case. So why epinephrine? Why do we give that? Epinephrine has 3 effects, and a lot of you might be pretty familiar with these. It has alpha-1, beta-1, and beta-2 effects, the main ones that we worry about. So these are all playing on the sympathetic nervous system. The sympathetic nervous system, epinephrine is a big part of that, as are a few other things, but it has its effect on these 3 different receptors is really what we're looking at. So from an alpha-1 perspective, what does it do when epinephrine binds to alpha-1 receptors, mostly on the blood vessels and in the lungs? It's going to cause vasoconstriction. So it's going to try to take this and put it back to this. As a result of that, you'll actually see an increase in what's called the peripheral vascular resistance. So that's where if all of my blood vessels squeeze back up nice and tight, there's more resistance to that flow, which makes the blood pressure go up. In addition, you'll also see a decrease in that mucosal edema. So the angioedema or the edema in the airways or in the GI tract, especially if this is an ingested allergen, that's where the alpha-1 is exerting its effect. Nice tight blood vessels, get rid of that edema. From a beta-1 effect, we get increased inotropy. Inotropy is just a term that refers to how hard the heart is contracting. Many of you might be pretty familiar with the concept of preload by now. We've talked about it in a few different courses. And inotropy just means that if I fill up the heart with a certain amount of preload, normally I get like this much squish out of it. If I increase the inotropy, that's just telling the heart that for the same amount of preload, I want you to push it out harder and faster. So that's just going to increase how much fluid is and how hard it's coming out of the heart. So it's going to increase your cardiac output. Same thing with increased chronotropy, which just means you're going to get tachycardic, faster heart rate. And obviously we see that when we give somebody epinephrine, but also maybe due to the response that's going on from anaphylaxis in the first place. The last one here is beta-2, and beta-2 is probably pretty familiar to a lot of people. Obviously that's what we're attacking with things like Ventolin and salbutamol in asthma. And beta-2 from epinephrine does cause bronchodilation, right? So it's kind of funny because it causes vasoconstriction, but it causes bronchodilation. And that's just an effect of the cells and how the cellular pathways work in those different types of cells. Smooth muscle here and then vascular tissue here. So it's just a little bit different. So it causes bronchodilation and releases that airway constriction, decreases the wheeze, increases the ability to move air. The last effect that it has is actually, and I've circled it here, that means it's super important, is it actually decreases the mediator release. So what happens is this epinephrine goes all the way back here and it inhibits this mediator release from the mast cells itself, or maybe basophils or some other types of cells. But it stops the release of all these mediators from these mast cells. So it has a direct effect in actually stopping anaphylaxis, not just treating the symptoms by fixing this or your airways, but it actually inhibits the release of things from mast cells and other cells that have been brought into the game at that point. So that's why epinephrine is so dope. So we want to get in there, we want to give it. We want to give it relatively early if anaphylaxis is suspected. So there's a couple of other things we can just quickly talk about. And I did mention stuff like Ventolin or salbutamol. So should we give Ventolin or salbutamol in anaphylaxis? Probably not, at least not right away. If somebody's super wheezy, they've been stung by a bee, sometimes the link in the brain goes, oh, wheezy in the airways, give some Ventolin. Well, that's not a bad thing to think about. You also want to make sure that you're actually treating the anaphylaxis, treat the cause, give them the epinephrine, affect all of this. This will still cause bronchodilation and it'll start to stop what's actually going on. So giving salbutamol if somebody's still wheezy later, if all of the other symptoms have kind of gone away and they're still a bit wheezy, yeah, you can maybe consider giving them some Ventolin, but certainly not a first line thing or anything you should be jumping onto quickly. Another thing we'll talk about a lot is diphenhydramine. I'm just going to put Benadryl because it's shorter. So Benadryl is a histamine receptor blocker. Kind of makes intuitive sense that like, hey, if histamine is being a pain in the ass, what do we want to do? We want to block it. Let's stop the effect of that histamine, so let's give them some Benadryl. And that used to be recommended decades ago. That was kind of the thing. It's like, yeah, it makes sense. Give them a histamine blocker, it'll work. The problem is, it doesn't work. What happens is you think you've treated anaphylaxis or made an effect that you're blocking histamine and doing the right thing. And what they found is that people died because they didn't just get epinephrine. And so that's one of the reasons Benadryl used to be out there a lot, used to be used a lot. Even in ACP cars, I think it mostly just, honestly, just goes out of date these days. Benadryl is a second line treatment. It can be used for some symptom relief, maybe if you're still itchy or something like that, but it's way down the list of stuff we need to do. From a pre-hospital perspective, anaphylaxis, you've decided that's what it is, you give some epinephrine. The rest of your focus should probably be on treating additional things. Epinephrine will help, it will do all these things, but don't forget, we're still dealing with distributive shock here. So what else might we want to do that's pretty useful? Before I was doing any of these, I would probably be making sure that I have an IV. For PCP and above, an IV fluid is good, right? Fill this guy back up. This will start to work by causing some vasoconstriction, but these people might still need some fluid in them. So some boluses of fluid, mindful, of course, of all the, whenever we give somebody boluses of fluid, we want to make sure we're not causing harm. But for the most part, it's probably going to be a good idea because we want to treat this distributive shock not just one way, but let's treat it with some IV fluid as well, right? So consider a bolus and just be mindful of the effects of giving fluid, like maybe pulmonary edema or something like that. So certainly before we start to consider adjunctive therapies, you could even make a case now. We have hydrocortisone and sometimes steroids are given in anaphylaxis. Those are usually given to prevent what's called a biphasic reaction, which is when like we fix it, it goes away, but then later on the body's like, meh, surprise, and you get all return to the effects of anaphylaxis. There's actually not great evidence to say that steroids do anything about that, but it's just kind of common practice to give them anyways. I think that that's probably a decision that's better left to the NP or physician or whoever's treating. In some wacky case, and I know we have a lot of different regions of this province and places that are way more isolated with long transport times, any adjunctive therapy other than epinephrine and an IV, I would strongly consider call EPOS, have a little chit chat, and see if there's anything else that might be effective. For the most part, I would stay away from Benadryl. Well, you don't have that on CAR perhaps. And steroids, I wouldn't jump into using those, even though we have the medication on CAR. We don't need to like find as many indications for it as we can. Focus on epi, focus on being ready with more epi, have a BVM out, have your suction ready to go, start an IV, boom, you're crushing this thing. So that's just a quick overview of anaphylaxis. It gets super complicated if you want to dig into it. We have access to UpToDate, everyone does. There's some great articles on the pathophysiology and treatment of anaphylaxis, and I'll put a couple other links at the end here. So hope that helps. Just a quick little look at it. If you have any questions, please feel free to reach out to me, kevin.lambert@bchs.ca, or any of the other practice educators on the island or in your region, and they would love to talk to you. Right on. Have a good day. Bye.